Esse é o grande round do Hospital de Clínicas de Porto Alegre, em colaboração com a Faculdade de Medicina da Universidade Federal do Rio Grande do Sul. Hoje o encontro será sobre novos conceitos no rastreamento do câncer coloretal. Teremos a participação do Dr. Robert Smith, Senior Vice President for Cancer Screening in the American Cancer Society. Ele estará fazendo uma apresentação inicial, que será seguida de uma discussão plenária, com participação em tempo real do Dr. Paulo Contu, professor e chefe do Serviço de Coloproctologia do Hospital de Clínicas de Porto Alegre, e o Dr. Daniel Damin, professor do Serviço de Coloproctologia do Hospital de Clínicas de Porto Alegre. Esse encontro será conduzido em inglês e em português, e em sequência eu estarei fazendo a conversão da língua para introduzir o nosso convidado internacional. Today's grand round will be conducted bilingual, addressing new concepts in colorectal cancer screening. The screening of colorectal cancer is associated to a reduction in incidence and mortality, and should be performed in general population. Most American medical societies recommend colonoscopy, since it has highest sensitivity for both colorectal cancer and benign polyps. At least 6 screening tests are presently available, showing different sensitivities and specificities, and shared decision-making is always recommended. I will invite Dr. Paulo Contu to best make the presentation of our guest. Please, Dr. Contu, you can talk now.
Dear HCPA community, it's my pleasure to introduce the speaker of this grand round, Professor Robert Smith. Dr. Smith is an epidemiologist and Senior Vice President in Cancer Screening of the Department of Cancer Control at the National Office of the American Cancer Society in Atlanta, Georgia. Dr. Smith also is an adjunct professor of epidemiology at the Rollins School of Public Health at Emory University School of Medicine. Professor Smith serves on many international and national government and professional advisory committees and working groups. He has received numerous awards and honors, including the Medal of Honor from the International Agency for Research on Cancer of the World Health Association. At the American Cancer Society, Dr. Smith leads the development of cancer screening guidelines, and in 2018, he and his colleagues published an update of the American Cancer Society guidelines on colorectal cancer screening for average risk adults and impacted the scientific community. It's an honor to welcome you, Professor Smith. Thank you very much for accepting the invitation to participate in our Grand Round lecture. Please take your time and share your knowledge. After your presentation, Professor Damin will conduct the discussion.
Dr. Smith, you can make your presentation now, please.
Okay. Yes. Thank you very, very much for the invitation to be with you here today. I'm very much looked forward to it, and will do my very best to keep it within the boundaries of our time so that we can have a good discussion. Next slide, please. I have no interest to declare. Next slide. So I thought I would give a sort of a short outline of the topics that I would discuss today. The burden of disease and rising incidence in young adults, which is increasingly being observed in countries around the world. The importance of identifying adults from high-risk families, which has the potential to avert a significant fraction of unanticipated and premature deaths that had their roots in a younger age at incidence. The value of screening with a high sensitivity stool test, and actually look forward to speaking some about that also. The critical importance of follow-up colonoscopy that should not be thought of as diagnostic in my judgment, but should be thought of as part of the screening continuum, where the stool test gathers information to distinguish between cases that are positive and negative, but we don't know anything until we've actually had the endoscopy. It is important to understand that colonoscopy has high sensitivity and high specificity, but that high sensitivity and specificity depends enormously on high quality. And what means quality assurance programs for colorectal screening with colonoscopy or for follow-up of positive stool tests are no less critical in either instance. And finally, I think we have to expect that in the future, we are going to increasingly be relying on blood-based screening tests for all the cancers. In fact, the pace of discovery is bewilderingly rapid. And I'll speak something about that with respect to colorectal cancer at the end as well. Next slide, please. All right, so on to the disease burden. We're very fortunate that we have IARC to present us with timely data, not only globally, but around the world. And as you've seen, that colorectal cancer is the third most common cancer diagnosed in the world. The rate of cases is growing rather dramatically with modernization, and it is the second leading cause of death from colorectal cancer. Next slide, please. The incidence rates are much higher in high development index countries versus low and medium high development index countries. And the mortality rate varies differently also because of the worse survival in the lower income countries. Rising incidence and mortality is associated with the lifestyles in high development index countries, associated with changes in lifestyles associated with colorectal cancer. Next slide, please. Now, these maps are always instructive, and so to the left you can see South America, which is of greatest interest to you. Uruguay stands out as having the highest rates, but the incidence rates are actually quite similar to many of the other countries in North America. Next slide. And these are our mortality rates, which are in parallel, but as you can see that even in some countries that have lower incidence rates, but have less, also weaker health systems, their mortality rate is much higher. The case fatality rate is significantly higher. Next slide, please. These are region-specific incidence, age standardized rates for sex of the colon and rectum in 2020. And again, they're ranked, of course, by the incidence, and you can see I've highlighted South America in each instance. The rates are not terribly different, actually, even though they are declining, not uniformly high or low, but they also are changing over time. And we can expect a greater burden of disease going forward. Next slide, please. These are data that you're all familiar with, but I thought I would put them up anyway. These are the incidence and mortality rates of colorectal cancer compared with the other cancers in Brazil in 2020. Colorectal cancer ranks 4th overall in deaths and 3rd overall in incidence. Next slide, please. And this is also a nice feature of the IARC website. It can allow you to do projections over time. And as you can see, as a function of rising incidence as well as demographic changes, we can expect a substantial increase in colorectal cancer incidence really over the next 20 years. Next slide, please. Now, these are some recent data from Brazil, and as I was going over much of the literature, actually I'm pleased to see that I recognized any number of your names from the people I've seen on this invitation list. The point of this particular article on the scenario of colorectal cancer in southeastern Brazil is that at present the predominant stage of diagnosis is advanced in colorectal cancer. This is just from one case series in a hospital, but it shows very, very few cancers are diagnosed at stage 1 and stage 2, and most of them diagnosed at stage 3 and stage 4. Next slide, please. And in terms of the trends, this is a very nice paper that looked at the trends in all cancers in Brazil, a 4-decade analysis. And they focused principally on the dominant ones for which we can have screening right now, although I don't imagine there's much lung cancer screening taking place. But as you can see, among women on the left and in men on the right, colorectal cancer is increasing over this period of time between 1980 and 2017. And these are between the capitals and then also the rural areas. Next slide, please. Now, of particular note, and we've known this for some time now, we've observed the incidence of colorectal cancer in adults under the age of 50. And 50 has been the benchmark because it's an age at which we have conventionally begun screening since the mid-1990s. If you look at the historical literature, there is actually a great deal of interest in promoting screening beginning at the age of 40. A great deal of interest, back in, the 20th century in screening with digital rectal examination at earlier ages. Even before that, people were being encouraged to undergo proctosigmoidoscopy with a rigid scope just to identify any early growths in the colon, as colorectal cancer was increasingly recognized as a progressive disease that had an adenoma carcinoma sequence. So, while we watched this incidence rising below the age of 50, people were not entirely sure what it was about. And increasingly, we've begun to see this occurring in other countries with screening programs, with organized screening programs, or at least a high rate of participation in opportunistic screening. And what we've seen is in adults 50 years and older, and frankly, this, at least in the United States, needs to be age 55 and older, we've seen steadily declining incidence as a result of the cases that we're preventing from detecting advanced adenomas and removing them, and the cases that we find early, the colorectal cancer cases we find early, that avoid a premature death. So both incidence and mortality has been declining in these older age groups that are within the age groups recommended for screening. But paradoxically, between the ages of 20 and 49 years, in Australia, New Zealand, Canada, the US, and other countries, we are seeing rising incidence in these adults. And it's been noticed, it's not been understood, and of course in those very younger ages, it wasn't a great deal of concern, more of an epidemiologic curiosity than a concern about the burden of disease. Next slide, please. But as this incidence has become starting to grow more and more, we have become more concerned about the burden of disease. And where this rise in incidence has become more apparent, it's led to other countries to begin looking at the rates in their own younger population. And I came across this paper from Brazil in Sao Paulo that also looked at the trend in the proportion of cases diagnosed under the age of 50 over time, and saw an increase in the annual rate, or increase of between close to 2 to 2.5%, with a relative increase of about 35% over a roughly 5-year period. Next slide. And as we dug into this, you mentioned our update in our guidelines in 2018. When we do a guideline update, we basically fall back on all the core principles from the WHO in the 60s and Wilson and Junger. And we say, all right, let's carefully examine the burden of disease. When we were thinking perhaps we should be looking more carefully at incidence rates in Black Americans to see whether we should actually begin screening them earlier, we discovered that the incidence rate was principally increasing in white Americans in both colon cancer and rectal cancer. And in fact, if you look at an incidence-based mortality, in other words, we're looking at the deaths that occur from incident colorectal cancers based upon the age of diagnosis, which is really what's most important. We care less about the age of death than when somebody would ultimately die from a case diagnosed when you might have introduced screening. We saw that about 10% of all life years lost in the US is attributable to a diagnosis between the ages of 45 and 49. And that got us to take this issue of earlier onset colorectal cancer really seriously. Next slide.
the internet difficulties you're having today. So I ask you for your patience. We are trying to fix it, and we will return in a few minutes, please.
Okay, no worries at all.
Okay, we're back.
Okay.
Sorry, Professor.
That's all right. That's all right. You know, this is, back to what I was saying, this is a very simple thing, collecting a family history. It is a more complicated thing to actually detect 1 in 4 early cases of colorectal cancer simply by taking a good family history. Next slide, please. So just also a very nice paper. This is from Chaik Duboni and his colleagues on a PROSPER study for which I was on the advisory committee. And we were having a meeting, and one day I said to the colleagues, I said, you know, here at Kaiser, you've got such good records, Kaiser Permanente of Northern California. You have such good records, so why not take all the colorectal cancer deaths over a fixed period of time and explain why they occurred? I mean, just in the context of screening, just try to explain why they occurred. And the most remarkable thing here is that literally the large majority of these cases are attributable either to a failure to screen at appropriate intervals, failure to follow up a positive screening test, failure to receive surveillance if you are at higher risk. In other words, you just fell off regular screening, and failure of the screening test. In other words, the screening test had poor quality and did not pick up the cancer. Next slide, please. Of particular relevance, I think, to many countries in the world is what happens if you do not follow up a positive stool test. That adults with a positive stool test that did not get adequately followed up are 8 times as likely to die of colorectal cancer than someone else. So than someone who, you know, had actually, you know, properly undergone screening like that. It's a remarkable, and we have a very serious problem in the U.S. Because most of the people who are undergoing stool testing are low income and do not have easy access to follow-up colonoscopy after they've had positive findings. And so quite often, I think, without anybody being responsible for that follow-up, it just falls off their radar and they don't get any additional testing. So it's absolutely critical to think of any stool testing program as having follow-up endoscopy as being part of the screening test. And that the test is actually not complete if it's positive until the follow-up colonoscopy has taken place. Next slide, please. So let's talk about stool tests. You know, it's been quite amazing to me that we are still using guaiac-based tests, and quite amazing to me in the United States that we still use low sensitivity guaiac-based tests. A very important study that was done by Collins, some years ago, showed that the sensitivity of an unrehydrated stool test, Hemocult-2, was about 14%. That literally somebody undergoing annual screening would have a very, very weak chance of having their colorectal cancer detected if they took a standard Hemocult-2 home, completed all 3 panels of it. They had much, much greater likelihood of having a colorectal cancer missed than actually detected. Fecal immunochemical tests, of course, are much more accurate, and they're much more patient-friendly. Some of them require only a single sample, and people have indicated that they like them much, much more. Cologuard now, the stool DNA test, the multi-target stool DNA test, is a very, very good test, but it's also very expensive and generally not affordable in many, many settings. Next slide, please. Now, the advantages of FIT, of course, is that it has high specificity for human blood and for lower GI bleeding. There's no interference with food or medications. Most brands require only 1 or 2 specimens. It's preferred by patients, and it has greater sensitivity. Next slide, please. And, you know, in the U.S. in particular, where we have a large fraction of our population that may not be covered by health insurance or may not have access to colonoscopy, we try to stress repeatedly that a program of high sensitivity FIT testing puts much less stress on colonoscopy services, as you can see here. And so it becomes a much more efficient way to screen. And I want to emphasize, when in the United States, and I think this is not a problem in Brazil, but when the referring physician says, oh, and by the way, you need to get your colonoscopy, they are just now learning that a large fraction of the patients have no intention of getting a colonoscopy. They do not want to undergo an invasive test. And our data show us that when you offer patients a choice between a stool test that they can take home or a colonoscopy, a very high percentage of them will choose the stool test, which means that you could increase your colorectal cancer screening rates if you gave people a choice. And I'm going to speak more about that later. Next slide, please. Another big problem, I'm not sure if this is a problem in Brazil, but it's certainly a problem in the United States, is that stool tests are what we call second-class citizens. They're viewed as much less effective than colonoscopy. They're viewed as a test that is second-rate. And so oftentimes, if you cannot offer the patient a colonoscopy, you don't offer them anything. Or if the patient would prefer to, if you are offering your patients colonoscopy, you don't want to give them a choice because you believe the colonoscopy is the much better test. But what modeling shows us, that adherence to any of these screening tests, according to the recommended guidelines, will produce very nearly the same results after a lifetime of screening as colonoscopy. So the idea that someone would be adherent to a simple high sensitivity test that they can do at home without undergoing an invasive procedure, and it could deliver literally the same results with many fewer colonoscopies. And let me be honest, that our harms associated with colonoscopy are not normally distributed across the age groups that we invite to screening. They are much more common in older adults, and even hybrid models of screening where after you have had a series of normal examinations, you could shift to stool testing, FIT testing in particular, to reduce your risk of an adverse event during colonoscopy. Makes a great deal of sense. It's not in a guideline yet, but I think it may not be many years before we start taking this kind of an approach. Next slide, please. The American Cancer Society has decision aids to help people understand what they're supposed to do and how to undergo these tests and why they're valuable. And we have cards for every one of the tests, as you mentioned earlier, that the 6 different choices that are available, you know, for screening right now. These may be downloaded, and if you wished, you could adapt them for your own use in Brazil. Next slide, please. Now, I wanted to talk about quality issues with colonoscopy, which is something that does not get a lot of attention. But when we refer to colonoscopy as a gold standard, it's best to think of that gold standard as a standard by which we measure the performance of other screening tests with a direct visual examination. And we have already seen literature on CT colonography, where CT colonography picked up lesions that the endoscopist did not. But these are all the issues that may actually complicate colonoscopy. And unless the endoscopist is getting regular feedback on their performance, they have no idea as to how well they're performing. It does not mean that anybody intentionally does a poor job, but they must get feedback. And in particular, they must get feedback on the adenoma detection rate, the cecal intubation rate, the rate of a well-prepared, prepped patient, and not only the adenoma detection rate, but the multiple adenoma detection rate, because we have seen, at least in the US, that there's a tendency once you find one adenoma that you're unlikely to find another one. Next slide, please. Now, the adenoma detection rate we observed is highly variable. In one large series, it varied from 7% to 52%. A low adenoma detection rate is associated with a higher interval cancer rate. Now, while all of these data are associated with screening, they apply to follow-up colonoscopy after a positive stool test just as much. Next slide, please. Now, this is in one series of individual physicians performing colonoscopy, 157 physicians, and you can see there is a wide range of adenoma detection rates in this series. And with really only 57% exceeding a 20% single adenoma target for female patients. Next slide. In this very nice study in Kaiser, they looked at the adenoma detection rate and risk of colorectal cancer incidence, interval cancers, and death. Next slide. Substantial person years of follow-up, and as you can see, these hazard ratios associating the adenoma detection rate and the risk of advanced stage colorectal cancer and fatal colorectal cancer, that the lower the adenoma detection rate, the higher the risk of colorectal cancer death and advanced stage colorectal cancer. Next slide, please. These are some of the key quality indicators, and there are well-developed strategies for helping endoscopists get better at detecting colorectal cancer, adenomas, and cancer. There's been a lot of emphasis placed on the withdrawal rate. And in fact, what we've observed is that longer withdrawal times are not a function of lingering during the examination and timing your withdrawal. They're a function of concentrating and knowing how to better detect adenomas, and that means that you're spending more time in the examination. Next slide, please. Finally, I think towards the end here, we want to talk about the future. For many, many years, we would get press releases from universities about blood-based screening tests that were looking for various different markers in the blood. And invariably, they tended to be heavily dependent upon tumor burden. So while it looks very exciting, right, to be testing for methylation or aberrant DNA, what we would be able to say is, yes, we have these primitive and rather medieval tests that actually do a better job at finding colorectal cancer or breast cancer earlier in their natural history than these more technologically sophisticated tests that nonetheless are heavily influenced by tumor burden, and their highest performance is in those cancers that are advanced. That's really beginning to change, and this was a study that was done in Brazil between 2010 and 2016, looking at a number of DNA methylation markers, at least one in particular that is associated with the methylated septin9 DNA test. And the authors concluded that the blood tests really at this point in time were not necessarily ready for screening because of their high variability in their sensitivity and specificity, but they did see some potential for using these as biomarker tests to identify the serrated polyps, which are oftentimes hard to pick up during colonoscopy. Next slide. This is some of the histograms, and you can see that the markers are really doing quite well. They just tend to have very poor specificity, which means that you would send a lot of patients to colonoscopy for follow-up. Next slide. So on that note, what I want to emphasize is that it's important to consider screening strategies in terms of population-based outcomes. It's very common, you say in the United States where you have a choice of tests, if you're given an option of choosing tests, a surprising number of people will choose one test over another. People who will choose Cologuard, they will choose to do their screening test by boxing up an entire bowel movement and mailing it to a lab. There's some people who prefer a FIT test. There's some people who like the idea of CT colonography. Most people get colonoscopy, but given choices, that rate would not be so high. In countries with organized screening programs, the tendency has been to offer a single screening test, and that screening test may not be desirable to everyone in the population. So the decision to offer an alternative screening test so that patients would have a choice between one or another could actually increase the population-based cancer and adenoma detection rate. And countries such as the Netherlands, for example, and in Italy are doing studies right now to determine the acceptability of not just one test, but two tests. It may be that the highest performing test may not be the most productive test. Or it may be that, for example, in the case of methylated septin-9, the FDA in the United States approved the test for use in patients that had consistently refused all other recommended screening options. Now, we believe that this was actually a non-starter, that primary care physicians would be very likely with a patient in the office to not be adherent with that particular recommendation, because the ability to just get a simple blood test when they may be getting blood tests for blood sugar, for triglycerides, for PSA, would be very appealing to the patient. And so they would have a screening test that was less sensitive than FIT, a little bit less sensitive than FIT, but with much worse specificity. Now, the way I viewed this is if the patient was old enough to be covered by Medicare, then a positive screening test would mean that they would be referred for colonoscopy. And if the colonoscopy was normal at the age of 65 or older, that would be their last screening test in a lifetime. So in fact, if you could increase your screening rate by 20% by using a reasonably performing blood test that wasn't as good as the stool test, you would actually save many, many more lives than not getting those patients screened at all. So I think this is something that we have to be a little bit more flexible going forward as to the scenarios that we could apply on a population-based level to actually increase our overall screening rates. Next slide, please. Now, I know that we're a little bit past 30 minutes from when we started. We had a bit of a hiccup with the internet, so I'm going to try to go through these slides right now very quickly. The American Cancer Society in 1997 established the National Colorectal Cancer Roundtable. We do not have organized screening. We don't have a system of healthcare in the United States. So the American Cancer Society pulls together all the leading organizations to work together to take on the challenges that the system isn't in place to take on. So we bring in all of our gastroenterological organizations, all our primary care organizations, our research organizations, the CDC, the NCI, the Center for Medicaid and Medicare Services, the advocacy groups, the radiologists, and the state health departments. And we have these regular meetings and these working groups, and we do small research projects to try to do what we can to increase colorectal cancer screening. Next slide, please. It means that you can harness the collective power and expertise of the entire colorectal cancer community, people who would like to find a way to make progress. And the more I've been thinking about this, the more I've been thinking, you can do this in every country in the world. There are challenges to increase awareness about colorectal cancer screening. There are ways to stimulate the uptake of quality assurance programs. Next slide. You can see these are some of the organizations that collaborate. And what we did in 2014, we launched an ambitious program to increase colorectal cancer screening by 80% by 2018. Next slide. And so we, in an effort to harness this effort, we had many meetings. We stimulated activities at the local level. We stimulated a lot of public media about screening, and we got many institutions across the country to establish a goal within their own hospital service, within their own health system, to make sure that they did everything they could to bring screening rates up from sometimes as little as 17% up to 80%. Next slide, please. Now, a good example is Kentucky. Kentucky had a very low screening rate. They ranked 49th in 1999, and we brought them up to 70%. I say we, the state, working in a very aggressive way, increased the colorectal cancer screening rate up to 70%. Next slide. And one of our colleagues said it's no coincidence that after a decade, after most state membership in the roundtable, we have risen to the most improved state in colorectal cancer screening rates. The collaboration with the roundtable and the tools that we provided to the state have allowed them to measurably increase their screening rates. Next slide. So a lot of this is motivation. Next slide. And what we've done right now is we've converted our 80% by 2018 goal into 80% in every community. And there the real challenge is to measure where there are deficits in screening, where there are consistently high rates of incidence, and take the steps to actually work to increase those rates, work to increase the follow-up rates, and measurably improve the performance. Next slide. Well, that's the end. So thank you very much.
Thank you, Dr. Smith. We still have some time for questions, and we will start a discussion now. I don't know if Dr. Demin or Dr.
Yes. Well, Dr. Smith, congratulations on your excellent presentation and very important and interesting information for us here in Brazil. And well, we have some questions for you. First of all, as colorectal surgeons, me and Dr. Paulo, we deal with colorectal cancer on daily basis. And every time we see a patient and make a diagnosis, let's say in a patient over 60 years old of age, we feel that something went wrong because this cancer could be prevented earlier, and along the way the system failed, or the information for the patient or the health system, something went wrong, and now we have to treat a cancer, and we could have treated a patient with a polyp of benign disease before, okay? But in our clinical practice, we have a challenge with our patients because 10 years interval for colonoscopies. Colonoscopy every 10 years, it's an effective, efficient way to perform screening for colorectal cancer. But our patients, let's say in private practice, they don't want to wait 10 years between colonoscopies. They don't feel safe about that. And I ask you, in patients that have insurance and access to the health system, would be valid at least to study a shorter interval between colonoscopies, something like 5 years. It could be tried, something like that.
Yeah, so we have this as a natural experiment in the United States, because even though we have a 10-year screening interval, we don't have an easy time keeping track of it. And nervousness about a 10-year interval is not unique to Brazil. I mean, we have this problem in the United States, both among the referring physicians and the patients. So we overutilize colonoscopy. People are called back at short intervals for hyperplastic polyps. There's not much adherence in the guidelines. My feeling has always been that the sensible thing to do is to have intervals, high sensitivity stool testing, as a way of minimizing the overuse of colonoscopy services, but giving the patient some peace of mind. In other words, if you could even do this twice. While people who are orthodox about evidence and guidelines would say, but the evidence doesn't support that, you could say, okay, maybe it's not terribly productive, but if it keeps the patient comfortable with a screening program and it reduces overutilization of endoscopy services, then it could be a very sensible thing. Not to mention the fact that colonoscopy is not perfect. It will miss things. And so the ability to have a simple high sensitivity stool test at a reasonable interval is not altogether a bad idea.
Well, excuse me. Go ahead. May I? Okay, I have the feeling that the prevention of colorectal cancer today in the world is more related to education, since most of the decision making is making in sharing decision making. When you look into the numbers, the test that represents the best sensibility is colonoscopy with 95%, but the test with the best specificity is FIT with 96.4%. Despite that, we have a high index of perforation related to colonoscopy, like 0.15%. So what do you think, Dr. Smith, about sharing decision making in the approach for prevention in colorectal cancer? Making
well, I think
the
it's very
patient,
yes,
the patient knew about this data.
It's very important that patients know what the limitations of the test and the potential downsides of the test. You know, in a quality program, perforations go down. They're certainly more likely to occur in older adults than younger adults. There's a real advantage to having a well-screened adult by the time that risk is higher, so that you could rely on a less invasive test to continue colorectal cancer screening. But I think truly it's important that patients know what to expect, because in the United States, we certainly have no shortage of people who experienced a perforation, ended up with a hospital stay, a post-colonoscopy bleeding, and they will report that they had no idea that could have happened and that they wouldn't have gotten the test if they had known. Now, I think probably even people who've in a shared decision making who heard it could happen didn't believe it could happen, and once it did happen, they would argue that they never would have done it. But I think, you know, it's we can minimize perforations by increasing the skill of the endoscopist, making sure also that we are careful about who we screen with colonoscopy, and ideally bringing patients at a certain point with a history of screening, so that colonoscopy may not be the obvious choice of test. If somebody were to ask me what if their first screening examination was they were approaching the age of 70, and they had any risk factors for colorectal cancer, I'd probably say it's a good idea for you to have a colonoscopy. You know, at your age, no prior screening history. Let's not fool around. You know, let's go ahead and do an assessment of whether or not you have some significant lesions in the colon. I find myself wondering if a person has had a normal colonoscopy at the age of 45, a normal colonoscopy at the age of 55, and a normal colonoscopy at the age of 65, do they need any more colonoscopies? Maybe even after the age of 55, they don't. I mean, I really hope we can gather these data over time so that we can, you know, minimize the potential harms as people get older and are more vulnerable, you know, to harms during colonoscopy. Or you do have an alternative such as CT colonography, for example, you know, which would also allow you to have a direct visualization of the colon, and at the same time, only potential risk is through, you know, just insulfation.
Maybe the association between FIT and CT colonography should be a very interesting approach. Do you think so?
Oh yeah, we've published several papers, and one some years ago that showed that a hybrid model of screening first with FIT and then with colonoscopy produced about the same results as screening only with colonoscopy. And it minimized the use of colonoscopy services, minimized the exposure to colonoscopy when the patient didn't have colorectal cancer, and also didn't leave the patient reassured that they had a normal examination when important lesions had not been detected. So the ability to use a combination of markers, in effect, blood-based markers or molecular markers with direct visualization, I think is a very sensible strategy to work out in a cost-effective way.
And probably we will have a better acceptance in the population.
Well, I think so. So, for example, you know, in the U.S., if you're at high risk for colorectal cancer, we do not recommend stool testing. We recommend colonoscopy. And these are patients who, not all of them are going to develop colorectal cancer, but you want to have a very sensitive, careful examination in a person with a family history or a person with Lynch syndrome, you know, to make sure that you detect any polyps that may be growing. If you think back about the results of the National Polyp Study, those were all meticulously very lengthy examinations. Those patients had, I mean, millimeter by millimeter, their colons were inspected. And so they, people who didn't have any polyps never developed colorectal cancer.
There is a question from the audience asking if FIT is available already in Brazil.
I'm probably the wrong person to answer that question, but there are studies in the literature of pilot tests using FIT in Brazil.
Yes, it is available.
Let me emphasize, though, that not all FIT tests are created equally, that some are more sensitive than others, and it's very important to use a test that has been validated in a population-based study of screening.
Dani e Paulo, vocês gostariam de acrescentar alguma coisa a respeito da utilização do FIT no Brasil?
Well, it's been used here, but I don't think that it's there is a screening regular program in practice right now for that. But may I ask one more question to Professor Smith, Dr. Fleck?
Sure, go ahead.
Okay, Dr. Smith. As we see a trend and an increase in incidence in colorectal cancer in the age between 40 and 50 years, would you think that it could be, that this fact could be a rationale to maybe propose beginning the screening at the age of 35, a decade before?
It's a very good question, because ultimately with colorectal cancer screening, you want to have an opportunity to detect adenomas. And that's always been the logic. You know, people would say that this incidence of colorectal cancer at the age of 50 wasn't so high. You'd say, yeah, well, it's high enough, but we also have an opportunity. If you looked at the detection rate of advanced neoplasia, now it becomes respectable, you know, from a disease control standpoint, because we want to prevent this disease when we can, and we want to find it very early in its natural history when we can. The modeling that we've done in the United States shows that it could be reasonable to start at the age of 40. We believe that it will be in a few years. I say a few years, I would say 5 or more years. The incidence rates may be such that the same logic that applied to dropping the age at 45 may support dropping the age to age 40. It would be ideal if we had a better way to identify those people at a younger age who really need to be screened, and have a more risk-based strategy. But right now, estimating individual risk is not very productive. I mean, we can do it pretty well for aggregate numbers of people, but not for individuals. But if this trend continues, we will see the age to begin screening starting to get lower. And it always makes me laugh a bit to think that in this modern age, you know, and all of us can reflect on this, no matter what our ages, We only do things in annual intervals, 5-year intervals, or 10-year intervals. You know, we just can't give that up. You know, and so it might be quite reasonable to say, look, everybody needs to start screening at 44 now. You know, that's a whole year that a colorectal cancer would have time to grow, an adenoma would have time to grow, when the prevalence is as high then as it was at 45. So we're going to start a year early. We're not going to wait until we can start 5 years earlier. Just like we could screen for breast cancer every 18 months or every 10 months. You know, I mean, we have computers, we can do this. But, you know, we don't. We tend to do 1 year, 2 years, 5 years, 10 years.
We are getting to the end of the meeting, but we still have time for a question of Dr. Paulo do Conto.
Thank you, Dr. Smith. As it seemed to me that as an excellent epidemiologist, you take a look to the population properly. And we are talking about fecal occult blood tests, but besides it is disposable, the high sensitivity fecal occult blood test, we have a problem about public health here. This test is not available for the people that use the public health in Brazil. This year, our National Cancer Institute, based on Rio de Janeiro, published a free electronic work on early detection in cancer in general. According to it, the most recent recommendation from Brazil's Ministry of Health is from 2010. We are late 11 years about these recommendations. So we have a great income to challenge. I have just one question to if I can understand your movement when you formed the group that built the guidelines. I understood that you looked to disparities among population groups in America.
Yes.
Am I correct?
Yes, yes.
In your opinion, what is the reason of these disparities among those groups?
It's very complicated, and there's a growing awareness in the U.S. that the progress that we have made is to not put the entire burden of disparities on the individual's education and their low income and their lack of medical literacy, right? We're appreciating more and more, we've always known this, of course, is that if you don't have health insurance, you are not likely to be able to get health care. You're definitely not likely to be able to get preventive care. If you're low income and poor, you're more likely to have more health problems. So when you see the doctor, there's little time for discussing prevention. The physician has to take care of chronic and acute healthcare problems. We also know that within our health systems, we have implicit bias against race, against social class, against people who are obese, people who live in rural areas, and they don't get the same quality of care as people who are more affluent. They don't have the same duration of care as people who are more affluent. So the challenge that we face today is to make sure that you at least sweep aside the financial barriers to healthcare. Then the social barriers, I think, are easier to address. I gave a talk on Sustained Development Goals, the UN Sustained Development Goals, and was very impressed with the, I hope I'm correct about this, that Brazil had modified its primary care system to create a population-based approach. And that this, to me, seems to hold the possibility of a kind of a population-based approach to simply administering a simple stool test. And in fact, if the immunochemical tests are, and they're more expensive than the guaiac-based tests, if the guaiac-based tests are just adequately rehydrated, which means that we're not so afraid of false positives, because the Minnesota trial that was so successful in showing that colorectal cancer screening with a guaiac-based stool test could significantly reduce colorectal cancer mortality and incidence, those stool tests were heavily rehydrated. And they worked very well. You know, a cheap, simple FOBT. But when we decided that the false positives were too high, we threw the sensitivity out the window. And it was only when the studies were done comparing Cologuard, the stool DNA test, the previous one was Pregen Plus, to the predicate stool test, we were startled to see how poorly the guaiac-based, unrehydrated guaiac-based test did. I mean, terrible sensitivity. And if you use a Sensa, you get much better sensitivity, but it's more expensive. So.
Well, unfortunately, we are getting to the end of this meeting. I would like to thank you very much, Dr. Robert Smith, who is the Senior Vice President for Cancer Screening in the American Cancer Society. I also would like to thank Dr. Paulo Contu, as a professor and chief of the colorectal service in our hospital, and Dr. Damin, who is a professor in colorectal section of our hospital. Thank you very much for everyone. It was a wonderful meeting, and I think that we have a chance to see all of you in the next future. Thank you very much. Bye.
Thank you for your invitation. Goodbye.
Thank you. You are closing the presentation now.
We are very grateful for your kindness, your interest, and brilliant exhibition. I hope we can meet each other someday.
I hope so too. I enjoyed this very much. And I reach out to me at any time if I can be of any help or contribute in any way.
Thank you. And if you're a fan, I wish a great season to Atlanta Falcons.
Thank you.
Bye-bye.
Bye. Thank you very much. Bye-bye.
Bye-bye.